Hello, everyone. I'm Mark Greiner from the University of Iowa. I'm really pleased to deliver this talk to you today on Acanthamoeba keratitis and what we are doing about it. I'm really grateful to be able to give this talk. I'm so grateful for the invitation to speak with you. I'm regretful that I'm not able to deliver this talk in person. I couldn't be there for travel-related reasons. Now, before I begin, I really just want to express my gratitude to the University of Iowa, the Department of Ophthalmology and Visual Sciences. We've been around for 100 years. We just celebrated our centennial. I really want to thank our photographers, our technicians, our patients, our students, in particular, Brittany Scruggs, one of my students who put together a lot of this work that I'm going to be presenting with you. We have a rich teaching history at University of Iowa that I'm pleased to help try and share a little bit. And with 100 years, that means we have 100 years of photos just like this that are quite graphic and excellent teaching examples. In Iowa, a principally agrarian, middle of the country locale, we've lived through Acanthamoeba. In the background, we've lived through sources of Acanthamoeba cases related to contact lens related solutions, flooding, and when I joined in 2012, we lived through a true epidemic of Acanthamoeba keratitis that we reported in Morbidity Mortality Weekly Report from the Centers of Disease Control. So many of you may be living fine lives vicariously through partners in cornea and external diseases like me and my colleagues, and you don't ever want to see anything that looks like this. Fortunately for cornea specialists, we do want to see things like this because we want to help. These are vexing cases, as you're going to hear continuously. And this is what we're up against: contact lenses. And that means that we all need to care because contact lenses, at least in the United States, are ubiquitous. And in the game of human versus microbe, nobody cares if you are a cornea specialist or not. We treat many ulcers. Many of these ulcers are contact lens associated in origin. They come from overwearing contact lenses, sleeping in them, showering in them, swimming in them, using non-approved contact lens solutions, poor contact lens hygiene in general. Any way you slice it, contact lenses keep me in business and fighting infections. Now, this is a very nasty looking picture, but it's not the scariest picture in this talk. By far and away, this is the scariest photo to me. When Dr. Christie extended the invitation to speak and suggested that I present on something that was relevant and indicative of the challenging cases that we face here at Iowa and what vexes us, I knew immediately that I had to present on Acanthamoeba. And immediately I thought of this case in particular that I would now like to share with you. This is the case of a 15-year-old contact lens wearer, an adolescent male, presenting to me at university 3 weeks on topical corticosteroid drops and antimicrobial drops, antibiotic drops. As well, he was treated by the referring doctor, a cornea specialist, with oral valacyclovir for symptoms that were related to light associated pain, severe pain with light photophobia, and not much in the way of findings on his corneal exam or on the rest of the ophthalmic examination. His presenting vision was excellent at 20/15. His intraocular pressure was normal. Everything else was normal on exam. And this is one of the things that vexes clinicians. How to identify the possibility that there's an occult microbial infection in a quiet appearing eye. Sometimes we can be sure by just looking very carefully at the image and what's causing the symptoms. You can look by location: central, peripheral, paracentral, pericentral. Other times like this, we can't see anything. So we rely on detective work. What do I mean by detective work? I mean relying on the clinical history that you elicit. In Acanthamoeba, which you have to have a very high index of suspicion to catch, you're listening for a history of contact lens wear. 95% of Acanthamoeba cases come from contact lens wearers. You're listening for freshwater exposure, exposure to organic matter, trauma. That's because Acanthamoeba is associated with water and soil. You're listening, of course, for signs and symptoms that are prototypically associated with Acanthamoeba keratitis infections, and you have to really listen carefully for these. Extreme photophobia, pain in the eye that's out of proportion, like sharp pain, even aching pain that really is elicited by light. Slit lamp examination. You have to be very, very careful and meticulous. The epithelium usually is intact in early to mid-stage acanthamoeba, and it can look like other things, like herpes simplex, or it can look like nothing at all. Now, here in this particular case, I didn't see this at first. There was a faint curvilinear inflammatory appearing stromal keratitis, and it turns out this is really what I was looking at was radial perineuritis. But this was such an innocuous finding that I blew past this. I watched the first time I met this patient. I said, continue your therapy. Let's see what happens in a week. So he was on corticosteroids, and ultimately he went on to develop this very obvious end stage appearing ring ulcer, obviously a late sign of acanthamoeba keratitis. This infection really ruined this patient's life. At 15, when he developed this, he had lots of pain and he turned to pain medicines, opioids, and he developed opioid dependence and really opioid addiction. He required therapeutic grafts. Actually, this was a bilateral infection. I'm just showing you one. The other looked just like it, behaved just like it. There was severe disruption to his schooling. He ultimately went on to university and got a scholarship, but due to the visual dysfunction and all the associated behaviors and need to treat this chronic problem, he dropped out of university. He turned to crime to support his opioid addiction. And I am really vexed by this case. I wonder what would I have done differently had I caught it earlier, or if someone had caught it earlier. And the point here is that steroids, corticosteroids, can really delay a diagnosis of acanthamoeba keratitis. In contact lens keratitis patients, you have to be very, very, very cognizant of the potential that what you're seeing really could be acanthamoeba keratitis early or masked. And now I teach from this case routinely. This is an unfortunately typical pattern. Acanthamoeba keratitis looks like HSV. And I want to impress upon you this main point. If it looks like herpetic keratitis and it is a contact lens wearer, you must rule out acanthamoeba keratitis. It's as simple as that. Herpetic keratitis in a contact lens wearer, you've got to rule out acanthamoeba. Let's talk a little bit about acanthamoeba. Acanthamoeba is ubiquitous. It's a free-living protozoa. There are more than 20 unique species of acanthamoeba, and it's a parasite. That means it feeds on bacteria and yeast, other microorganisms. There are two stages in the life cycle of acanthamoeba. There's the mobile trophozoite form, and then there are dormant cysts that form against pressure to try and kill these trophozoites. And it is a very, very difficult to treat infection, which is why I'm here talking about it, and you already know this. The actual cysts and the actual microorganisms are so small, 25 to 40 microns for the trophozoite, less than that for the cysts. They're so small, you need a microscope to see them. Enter confocal microscopy. Confocal microscopy permits histology grade detail throughout the cornea. And the basics I just want to cover. You know this. Briefly, when light strikes a surface, that light can be either reflected, transmitted, or absorbed. All three, of course, happen. The light that is reflected specularly, mirror-like, where the angle of reflection is equal to the angle of incidence, that's what's captured by the confocal microscope or a specular microscope, and that's what forms the image of interest. The pathway of light from its source in the clinical specular microscope comes back to the film plane of the same instrument. And that is exactly what's collected at the film plane. It's forming the image, and that's the part of the cornea where the instrument is focused. And you can focus down all the way through the entirety of the cornea in a confocal microscope. These images here are from the Heidelberg HRT3 with the Rostock module, and these are 400 by 400 micron image sizes. And I'm showing the depth because as we talk about how acanthamoeba infection happens, I want you to pay attention to the level of depth that we're talking about here. Acanthamoeba enters into the cornea through nicks or small breaks in the epithelium. And that's where you want to focus initially with confocal microscopy. Are there is there evidence of subepithelial or subbasal nerve plexus findings? Acanthamoeba keratitis tends to develop because Acanthamoeba gloms on, attaches to, is associated with the corneal nerves, hence the pain from the keratitis. So you focus on the epithelium and subbasal nerve plexus. If present, cysts that are there are most likely to be present early in infection, and that's where you're going to find them. So that's where you should look. As you go through the infection, deeper involvement occurs. The microorganisms progress and they get more deep with the more severe disease. And you can grade disease severity by how deep the infection is detected. Interestingly, Acanthamoeba does not perforate through the cornea into the anterior chamber. It can, however, travel retrograde via corneal nerves all the way through back, retrograde through sclera, causing a scleritis. You can even get associated retinitis, and it can be very, very difficult to treat these patients. What does it really look like on confocal? You're looking for bright white spots. They're uniform, spherical. Sometimes they have surrounding halos. You can see the outer wall and the inner body. So these kinds of double wall morphologies are very common with cysts. And cysts do pair together. They chain together. You can get clusters of them. And these are very suspicious for Acanthamoeba keratitis species. So bright white objects, think Acanthamoeba. So this is what our 15-year-old patient looked like. This is what clinched the diagnosis for me. Confocal microscopy, however, has some significant limitations. Confocal is not readily available at all centers. Confocal microscopes generally, at least in the States, I don't know about abroad, but my understanding is that they're not being manufactured anymore by the device manufacturers. That means that they're not practically serviceable. When they break down, they are out of service, and that can render a center paralyzed using this kind of ancillary imaging modality. And so confocal microscopes are truly precious resources, and they take a high level of skill to operate. So the reason why I think our techs originally here at the outset of our talk is because our technicians are really fantastic at working with our patients to get these images and clinch these diagnoses for us. So kudos to them. So the diagnosis is clinical, but in addition to classic slit lamp finding, confocal microscopy, we also perform diagnostic corneal scraping. Scraping. What do we do with our samples? We send them now for PCR testing. That's generally what we do here in the States. Um, there are centers that have that have laboratories that are able to do that, and not every center has it. We do send our samples out. Um, and you have to, sort of scrape into the anterior stroma to really get enough sample to send for PCR testing. What did we used to do? Way back, we used to have E. coli overlay agar plates. And we used to plate the sample and watch as acanthamoeba ate their way, causing visible tracks through the bacteria. And after that, sort of, in between E. coli overlay and plating and the PCR era, we also in our center used to obtain our scrapings and perform cytospin preparations, where we placed the samples in Salka monofixative, spun them down, and looked for evidence to detect cysts. But again, now molecular diagnosis is generally the way to go. And of course, treatment. We got to consider treatment. And what are we really doing with acanthamoeba once we make the diagnosis? So there's standard therapy, and these are the treatment considerations. There are topical biguanides, chlorhexidine, PHMB, and there are topical diamidines, propamidine, pentamidine. So these are pool cleaners. These are the mainstay of therapy still. Other agents are used sometimes, topical antifungals, in particular voriconazole. This has been described as useful in some cases. It's possible that what we're really treating isn't directly acanthamoeba, but rather occult fungal co-infections. Now, in the States, propamidine eye drops, Broline, not available. They're not FDA approved. But double coverage really does make sense to me, treating with both a biguanide and a diamidine. Patients can be on treatment for months to well over a year. And that's why it's really important to have a solid diagnosis before initiating therapy with these heavy duty topical agents. And sometimes, if I don't have a patient that can get diamidines, I'm double covering with two different biguanides. I'll use chlorhexidine and PHMB sometimes because it's very difficult to tell which treatment is actually being effective, and there can be really some treatment resistant organisms that are out there in the community. So, what's new on the horizon? What are we doing now? Nowadays, we are using PHMB 0.8% monotherapy. How are we getting this? Professor John Dart shows us the way. His recently published clinical trial data are quite convincing on the efficacy of this regimen. It remains to be seen if Acanthamoeba in Iowa behaves like Acanthamoeba in the United Kingdom, though. So what Professor Dart did in this trial was compared PHMB 0.08% monotherapy against PHMB 0.02% plus propamidine 0.1%. So a dual therapy. And what they were able to show is that there was a medical cure rate of 86%, which is really, really high for either treatment. And the findings ultimately supported their hypothesis that the 0.08% monotherapy is non-inferior, although not more effective than the dual therapy. So that's where we are starting to move with PHMB monotherapy 0.08%. And what really are we doing even more than that? Well, the most recent thing that we're doing is participating in the parasitic ulcer treatment trial. This is a trial brought to us from the good folks at the University of California, San Francisco Proctor Foundation, the same folks that brought us the SCUT and the MUT studies. The PUT is a multi-center parallel group randomized clinical trial. The purpose of the study is to determine whether including topical corticosteroids in an acanthamoeba treatment regimen will improve vision. Patients presenting to all the centers with evidence of acanthamoeba will be eligible if there's evidence of ocular inflammation after 4 weeks of dedicated anti-acanthamoeba therapy. So participants are agreeing to be randomized to either topical corticosteroids or topical placebo. And the inclusion criteria are a de facto acanthamoeba diagnosis, at least one of the following: culture, smear, PCR, shotgun sequencing, biopsy, confocal. So you got to have the solid diagnosis, and then inflammation after 1 month of dedicated acanthamoeba treatment. We're trying to standardize everyone. They may come in on various treatments, but we're trying to standardize patients ultimately to receive or get down to just PHMB 0.08% for a month, and then randomizing to either group. So stay tuned for how this is going to shake out. It's an exciting trial. And lastly, one of the treatment considerations that I want to bring to you is something that really has been impressive to us at Iowa, and that is the impact of intravenous pentamidine in the perioperative period for patients going for therapeutic keratoplasty. So you're talking about patients that have failed and need surgery to excise the disease. And what we've seen is we've seen a high rate of surgical cure achieved with perioperative use of IV pentamidine, a parenteral diamidine. So how is it used? Patients that I know that I'm taking to surgery, we start daily infusions of drug. Pentamidine requires monitoring. We co-manage with our internists. And, that's because there are side effects: liver, kidney toxicity. Patients can have a lot of GI upset. But if we can get them through, we have a high rate of surgical cure. And that was really published in our results of this, again, led by Dr. Scruggs. And so this is something that is very, very impactful when patients really do need to go to surgery. So, in summary, acanthamoeba keratitis, First, you got to suspect it. Classic history, exposure, pain out of proportion, photophobia, confocal for making that diagnosis. Very important. Point number two, acanthamoeba is classically misdiagnosed as herpes simplex keratitis, so you've got to have a high suspicion. And of course, initiating topical corticosteroids prior to a diagnosis of AK, that's a well-documented risk factor for poor outcomes. So you got to keep the first 2 points in mind. Thank you very, very much for your attention.